Good afternoon. Our lecture today is about anemia in pregnancy. The objectives of this lecture is to classify the types of anemia and explain the etiology behind each type. Describe how an anemic woman presented clinically. Study the effect of anemia on both mother and fetus. Discuss the methods of investigation and the treatment of each type. Now we come to definition of anemia. WHO define anemia as a hemoglobin level less than 11 gram per deciliter. Types of anemia. Anemia can be classified into A. Nutritional. It includes iron deficiency anemia, folate deficiency anemia, and B12 deficiency anemia. Such iron, folic acid, and B12 are called tonics. If they are deficient in the diet, it will cause anemia. Second type of anemia is a hemolytic type, which includes sickle cell syndrome. Such syndrome subdivided into sickle cell disease. It is a homozygous inheritance of hemoglobin S from both mother and father. Sickle cell triad, it is a heterozygous inheritance of hemoglobin S from only one parent. Thalassemia syndrome, it is subdivided into alpha thalassemia and beta thalassemia. G6PD anemia, hereditary spherocytosis, and autoimmune hemolytic anemia. Third type of anemia is a chronic type of anemia. Now we come to know the etiology of each type of such mentioned anemias. Iron deficiency anemia caused by decreased iron store, decreased dietary intake, decreased intestinal absorption, increased demand in pregnancy by the increase in red cell mass, so it needs 500 to 600 milligram of iron, and by the fetus 300 milligram. Folate deficiency anemia arise if there is decrease in dietary intake, increase renal clearance, transfer to the fetus about 800 microgram at term, increase demand in pregnancy by increased red cell mass and uterine hypertrophy. B12 deficiency anemia, such type of anemia is rare because it causes infertility. But if it arises, it is due to the dietary deficiency. Sickle cell anemia. There is a qualitative defect in synthesis of hemoglobin molecule. By substitution of valine to the glutamic acid amino acid in position 6 of beta chain. You know, normal hemoglobin molecule consists of 2 alpha chain and 2 beta chain. Each of these 4 chains consists of a series of amino acids. So if there is a qualitative defect in such chains, it will result sickle cell anemia. Thalassemia syndrome. Here, there is a quantitative defect in synthesis of either alpha chain or beta chain. So if there is deficiency in alpha chain, it causes alpha thalassemia. But if there is deficiency in synthesis of beta chain, so it causes beta thalassemia. Both types can be subdivided into major and minor. G6PD anemia arises from deficiency in the enzyme called glucose 6-pyruvate dehydrogenase, which is involved in metabolism of red cell. Chronic anemia can be caused by a chronic renal disease, chronic liver disease, hookworm infestation, and infection like malaria or human immune deficiency virus. What are the risk factors that increase the possibility of development of anemia in a pregnancy? Malnutrition, multiparity, low social class, poor education, short interval in between pregnancies, prolonged lactation, and teenage group. Maternal risk of anemia mean the effect of the anemia on the health of the mother. Number one, easy to get infection, difficult to perform usual work, antepartum hemorrhage, especially accidental hemorrhage in folate deficiency, preeclampsia, especially in hemoglobinopathy, postpartum hemorrhage, recurrent urinary tract infection mainly in thalassemia triad, delay recovery from anesthesia and delay in wound healing after cesarean section, deep venous thrombosis. Fetal risk include congenital anomalies as in neural tubal defect, cleft lip, cleft palate, mainly in folate deficiency, preterm labor, intrauterine growth retardation, intrauterine death, high perinatal mortality due to the high percentage of a preterm delivery. Neonatal anemia may be developed with behavioral changes. Clinical features of anemia include symptoms. We should have headache and blood vision, palpitation and shortness of breath, easy fatigue and intolerance to the exercise, generalized bone pain, nausea and vomiting, fainting attack in severe anemia, numbness and paresthesia in B12 deficiency. Signs include pallor discoloration of the skin and the mucous membranes, tachycardia and hypotension, ejection systolic murmur, angular stomatitis, loss of tongue papillae, and tongue ulcer in folate deficiency. Jaundice and hepatosplenomegaly in hemoglobinopathy, low blood pressure and rapid pulse rate, koilonychias in chronic type of anemia. Now we come to the clinical feature of sickle cell crisis. Sickle cell crisis usually develop in those with sickle cell disease, I mean hemoglobin SS. There may be sudden severe bone pain in upper and lower limbs, chest pain, hematuria, severe pallor and jaundice, hypotension and tachycardia. Now we come to the investigation that should be done to conclude what is the type of anemia the patient has. In iron deficiency anemia, there is decreased serum ferritin level, decreased serum iron level, increased total iron binding capacity, a blood film showing microcytic hypochromic red cell. Microcytic means decreased mean corpuscular volume. Hypochromic mean decreased mean corpuscular hemoglobin concentration. Bone marrow show absence of stainable iron. Folate deficiency anemia, we found decreased serum folate level, decreased red cell folate level, decreased reticulocyte, blood film showing macrocytic red cell, that mean increased mean corpuscular volume, and hypersegmentation of the nuclei of a neutrophil. Bone marrow showing erythroblast and giant metamyelocyte. B12 deficiency diagnosed by decrease in serum level of B12. For hemoglobinopathy, there is increased reticulocyte and decreased platelets and white BC count, increased serum bilirubin level, presence of bile pigment and urobilinogen in urine, blood film showing sickle-shaped red cell when exposed to reducing agent or hypoxia. This is called positive sickling test. There is normal mean corpuscular volume and mean corpuscular hemoglobin concentration, but if these are low, think about associated iron deficiency or thalassemia trait. Hemoglobin electrophoresis is the definitive test to know the type, amount, and character of such hemoglobin variant. Now we come how we treat each type of anemias. We start with iron deficiency anemia. Iron therapy is used either as a prophylactic or therapeutic. Prophylactic is given to asymptomatic pregnant patient to prevent development of anemia as the pregnancy increases demand for iron. It is usually started in second trimester. Therapeutic is given to symptomatic pregnant anemic women. Iron therapy can be given either as oral iron, it is presented as a ferrous sulfate tablet, which supplies 67 milligrams of elemental iron in 200 milligram tab. It is given 3 times daily. It is easily absorbed. Other oral preparations are ferrous fumarate and ferrous gluconate, which supply 37 milligram of elemental iron in 200 milligram tab. Nausea, vomiting, constipation are the common side effects. Such oral iron can be given if anemia develops early in pregnancy. Parenteral iron is indicated if there is poor iron absorption from the gastrointestinal tract, poor compliance of the patient, intolerance to the side effects. Parenteral iron can be given either as iron dextran or interferon, which is given through intravenous route as a bolus dose or infusion, or iron sorbitol, Jectoffer, given as intramuscular injection. The total dose required to correct anemia is calculated by the equation 1.3 multiplied by body weight multiplied by hemoglobin deficit. Both oral and parenteral iron have same efficacy, and response is assessed by rise in hemoglobin level by 1 to 2 grams per deciliter within 2 weeks. Blood transfusion is indicated in iron deficiency anemia if anemia develops late in pregnancy and hemoglobin is 8 grams or less, because we have no more time to correct anemia by oral preparation. Now we come to the folate deficiency anemia. It is given either as a prophylactic 1 milligram tab daily or as therapeutic 5 milligram tab oral route. It is also indicated in those with sickle cell disease even before a pregnancy as 5 milligram twice daily. Pre-pregnancy use of folic acid preparation can reduce the chance to develop a neural tubal defect. Folic acid tab is indicated as soon as a pregnancy diagnosed. B12 deficiency anemia is corrected by parenteral B12 ampoule containing 1000 microgram of B12 given once weekly. Hemoglobinopathy. Oral folic acid 5 milligram twice daily. Iron therapy can be given in sickle cell trait and thalassemia minor, but contraindicated in sickle cell disease since it causes hemosiderosis. Screening for urinary tract infection and treatment. Antepartum blood transfusion is indicated, particularly in those with sickle cell disease, to keep the hemoglobin A, which is anormal, constitutes 60% of whole hemoglobin. It is given either as a prophylactic or selective when hemoglobin level is less than 8 grams per deciliter. We should discontinue hydroxyurea, the drug used in the treatment of sickle cell disease, which increase hemoglobin F, so improve red cell hydration and decrease polymerization of hemoglobin S. It should be discontinued because it is teratogenic. Treatment of sickle cell crisis by adequate hydration, adequate oxygen supply, adequate analgesia and painkiller as pethidine or morphine, treatment of infection anywhere, a blood transfusion, and there is no indication for termination of the pregnancy. Now we come to the labor management. We keep the patient warm, adequate intravenous glucose water infusion to prevent dehydration and provide energy. Blood transfusion if hemoglobin level is 8 grams or less. Monitoring of fetal heart since the fetus is under stress due to hypoxia. Avoid prolonged labor. Early mobilization and chest physiotherapy after cesarean section. Thromboprophylaxis for those immobilized and those who develop a crisis. Anemia alone is not the indication for cesarean section. Thank you very much.